It's my pleasure to introduce our guest speaker for our educational program entitled Health Equity and Implicit Bias. Our format tonight is to hear from our guest speaker, followed by a panel of physicians who will react and respond to his presentation, provide some of their own insights about the topic. Our keynote presenter is one of the nation's leading scholars in the effort to eliminate racial and ethnic health disparities. Dr. Stephen Thomas has applied his expertise to address a variety of conditions from which minorities generally face far poorer outcomes, including cardiovascular disease, diabetes, obesity, and HIV and AIDS. He's a PI on the Center of Excellence in Race, Ethnicity, and Health Disparities Research. He's also a professor of health policy and management and director of the Maryland Center for Health Equity for the University of Maryland. Dr. Thomas has been an active participant in the COVID-19 update calls coordinated by Dr. Half and is also participating in MedChi's IDEA task force. Dr. Thomas received his master's degree in health education from Illinois State University and his PhD in community health education at Southern Illinois University. So Dr. Thomas, we welcome you and look forward to your timely, informative, and always thought-provoking presentations.
Thank you, Dr. Pham. I think I'm in between you and your group and the debate. So I'm just representing the actions that we all are going to participate in, right? In addition to getting the flu shot, we're going to vote. And we dropped our ballots off today in a drop box at the University of Maryland Xfinity Center. So I want to thank you very much for inviting me this evening, and I hope that it's a beginning and not an end. And I really want to say thank you. I heard that there were other chapters around the state that wanted to join this meeting, and I'm glad to have them available as well. I've got about 15, 20 minutes, I'm told. You've had a long evening. And I'm going to do my best to set the stage for, again, what I hope will be the beginnings of a partnership. I'm going to take a chance here and share my screen. Dr. Pham, will you cross your fingers for me?
They're crossed.
It should all work, but you never know. Okay, here we go. And I really encourage people to use the chat box for questions, and we'll, again, we won't be able to do it all, but we will definitely get a good start. This is my contact information. There may well be some things I say tonight you don't agree with, and that's fine. The issues we're facing are very complicated. We should not assume we're all going to agree on the same things, but we can agree to not be disagreeable with one another. So we need a space where we can grapple with the tough issues and still come away from it as friends. And Dr. Pham, that's why I think that in-person meetings will still be very, very important. These Zooms work now because you have relationship. Now imagine all the new scholars coming on board and they never meet you in person, it's all on Zoom, it begins to deteriorate over time. That's what we're learning in our own work in the community. So the title here is The Colors of COVID-19, Confronting Health Disparities and Implicit Racial Bias During a Global Pandemic. In many ways, as devastating as this pandemic has been, it has also illuminated the deferred maintenance of our public health infrastructure, as well as barriers, structural barriers in our healthcare delivery system that we now are forced to address. Greetings from our president at the University of Maryland, Dr. Darrell Pines. Can you imagine the first Black president, University of Maryland, flagship campus, and he arrives during the COVID pandemic. So the students have produced, this superhero image because there's nothing that he's discussing that is not touched by the COVID pandemic. It has touched every aspect of our lives. Small commercial, I'm guest editing a theme issue of the journal, International Journal of Environmental Research and Public Health. I would welcome contributions, Dr. Pham, from your audience here. They can be thought pieces. They can be, here's how we adjusted our practice in the face of the pandemic. It could be observations that people have made at the clinical level that have implications for addressing health disparities. And so I welcome contributions, and maybe we can even talk about that as the questions that get generated can maybe be addressed in an essay or a series of papers that we publish here in this theme issue. It has a January deadline. Tomorrow, I'm doing this presentation with colleagues at my medical historian, and I think that the history of medical mistrust is something that we encounter out in our community outreach. And I think it's very important that I simply not assume what's happening in the medical education and where do the physicians and nurses and other health professionals get exposure to the history of medical mistrust that has shaped the attitudes and behaviors of many communities of color over the decades. And then next week on the 28th, we will host our webinar, Engaging Communities of Color for Flu Vaccine Uptake by Breaking Through the COVID-19 Misinformation. The lineup is still being confirmed, and I was so glad to see Dr. Gales. I hope he's still on, because his staff is reaching out to him to be one of the panelists here, and so I hope to hear from him. And Dr. Michael Osterholm, I consider him second only to Anthony Fauci, has agreed to be part of the panel. And what's most interesting about Dr. Osterholm is he's agreed to go to the barbershop. He's going to interact and speak to the common man, common woman about these issues, and I hope help demystify what's going on. So please, if this is works on your schedules, join us. And then last but not least is the work that we're doing right now in the COVID vaccine space. We're right now recruiting for the Novavax vaccine that's Moderna has ended. Novavax is now starting. And I wanted to share this slide with you. If any of the practices have any interest whatsoever as individuals or for your patient populations to participate in the COVID-19 vaccine trials, this is how you reach us. Now with that, we'll go to the learning objectives. Dr. Pham, in the next 10, 15 minutes, I'm going to attempt to touch these 4 key issues so that at the end of this presentation, your audience will be able to describe the burdens of race and history underlying these structural inequalities and the social determinants of health associated with these excess burdens of COVID-19 illness and death. They'll be able to list unconscious bias and how it may impact delivery of medical care in public health services. They'll be able to describe the difference between institutional racism and in healthcare and tailored solutions with policy implications. And they'll be able to discuss the origins of bioethics and its roots in the history of biomedical research abuse of human subjects recruited from communities of color. Around this image are just photos of the different ways in which our Center for Health Equity has reached out across the state of Maryland to improve health outcomes for our most vulnerable citizens. For tonight, I'm going to focus on the solution box in the upper right, the Barbershop Health Initiative. Our motto across the board is building bridges, building trust, building healthy communities. The essence is to get off the campus, get into the neighborhoods, and bring all the science and technology that we've developed and translate it into culturally tailored community-based interventions. So our goal is to help retool the public health and medical workforce. And our theme is, how do you become a self-reflective physician? How do you become a self-reflective provider? How do you become a self-reflective researcher? And with that is one of our scientific products from our NIH research, our Center of Excellence, and it's called Building Trust Between Minorities and Researchers. It has implications for clinical practice. This is an online interactive website that we use in our own training. These are the different modules. So Dr. Pham, this is the formal module training. When I met with the IDEA task force, some of your members asked for very specific didactic training, hands-on training. Here are the modules. I'd love to follow up with you about how we can implement this for those of your members that are interested. And then I just simply go to the newspaper. I mean, every now and then, maybe in your careers, what you do, what you've always done, some ends up front page of the newspaper, ends up front page of the newspaper every day. And that's what's happening now in the work that I do. And so these are just some of the things that are going on that we confront in the community. The upper left, the flyers specifically saying COVID's a hoax, don't take the test, don't take the vaccine. We were seeing this circulated back in March. It's still happening. There are no countermeasures that we've been able to see to counter this. It doesn't help when our own elected officials and cabinet members are caught up in disseminating misinformation, as you can see in the headlines that we have right here. And it definitely doesn't help as these numbers are just staggering. And I'm almost convinced that we're getting numb. We're getting numb to the numbers. Behind those 247,000 projected deaths are loved ones, moms, dads, uncles, aunts. We've got to put the heartbeat back in these numbers. Dr. Fauci is also recognizing the mistrust that's going on, and some of this is systematic. And last but not least, look at this, Black patients, 72% more likely to be hospitalized. All of this is shaping attitudes and beliefs, not just towards COVID vaccine. It's shaping attitudes and beliefs towards taking the flu vaccine. It's shaping attitudes and beliefs towards going to the doctor for routine screening. And it doesn't help in my lifetime. I've never seen this, that public health officials under threat, needing security. And while Dr. Fauci is the most obvious and visible, many health directors around the country, or several, I'll say, have resigned. And if Dr. Gales is there, he may speak about his fellow colleagues. It is, I think, noteworthy that those who have resigned have happened to all be women who are health officers in some of these states. So this is an unprecedented dynamic that we're seeing at a time of a global pandemic, polarization in our country around issues of race, and this unfortunate dynamic of the direction of our country relative to our peers. Now, you might put a different label on these circles. I may not call United Kingdom, Canada, and France socialized medicine, but they definitely have single payer systems. You may or may not call our system for-profit healthcare, but let's just accept the fact that the graphs don't lie. We're going in the wrong direction, and other countries have figured something out that we haven't, or we've figured it out and don't have the political will to implement. At any rate, we're in for a really, really rough ride. And so I'll come back to pre-COVID. This is before COVID. If you're Black, breast cancer first diagnosed at stages 3 and 4. And you all know that the breakthroughs that we've made in medicine to save lives is directly related to what? Early detection, early intervention. How is it that in 2013, when this story ran, and I don't think it's changed that much, that Black women are showing up for the first time with advanced cancers? And that translates in ways in our own research that we learned that many African-American women simply did not think that the messages, the pink ribbons, the pink water fountains, the football players in pink shoes, the Susan Komen races, that it wasn't speaking to them, that it wasn't speaking to them. And I'll just go down to number 4, fear of diagnosis. For many white women, not all, but for many, to get that diagnosis is also a wellspring of social support. What we learned from our study is that for many African American women, that social support is not always there. And so the diagnosis means it can be even more isolated. As you can see here, all these things play out. Now they're in a complex mix of COVID, issues of racism, issues of medical distrust. Look at the caption. I won't be used as a guinea pig. That's not uncommon. We've heard that before. But this says, I won't be used as a guinea pig for white people. That's the polarization we're seeing, that somehow Blacks and Latinx communities will be used to test the vaccines, but they won't benefit from the final product. You can agree or disagree, but in our own top-line medical journals, you've got titles like this, Reparations as a Public Health Priority. It's this opening here. There has not been a single year since the founding of the United States when Black people in this country have not been sicker and died younger than their white counterparts. And then it goes on from there. So this is your peers, my peers, ringing a bell, ringing a bell. House is on fire. And so context matters. And you all know about this case. But Dr. Pham, I'm old enough to remember when nobody was learning about this in formal education. They now know about the Tuskegee study. 40 years, the longest non-therapeutic experiment on humans in the history of medicine and public health. But notice this doctor drawing the sample out in the field. My point is that many of the things that were done during the Tuskegee syphilis study are things that we would actually recommend today. Build trust with local leaders. Bring your clinical outreach to the neighborhoods where people are. In this case, they're in a plantation. My point is that the methods, while reprehensible in terms of their outcome, are some of the very things we need to do now. Also note this, that the white doctors who were the PIs and researchers of the Tuskegee syphilis study, they would be considered the good guys. They would be considered the guys in the white hat coming to save the community, a neglected community. So we have to ask ourselves, how might we be viewed 30 years from now? This is an example of the editorial cartoons that ran in 1972 when the story was broken in the front pages of the newspaper. It was never a secret. It was published in the medical journals at titles like 20-year retrospective of untreated syphilis in the Negro male. What's interesting here is that they used insight about the culture to get people to do what they wanted them to do. In this case, it was to consent for autopsy. If they consented for the autopsy, the government would pay an incentive of burial insurance. And for these poor farmers, that was a big deal. On May 16, 1997, President Bill Clinton issued a formal apology to the survivors of the Tuskegee study. There were 8 men still living. I was honored to be invited to the White House for this ceremony. Dr. Sandra Quinn and I had produced some of the scholarship that led to the justification for the apology. But it's this line here: the people who ran the study at Tuskegee diminished the stature of man by abandoning the most basic ethical precepts. They forgot their pledge to heal and repair. They had the power to heal the survivors and all the others, and they did not. Today, all we can do is apologize. An apology means I'm sorry, from a president who wasn't even alive in 1932 when the study began. I think we have to move towards atonement. Atonement, which means making things better. And I submit to you that the national campaign to eliminate racial and ethnic health disparities efforts here in the state of Maryland to address health disparities is actually part of that atonement. And it is my hope and expectation that the General Assembly will take up legislation to address health disparities in the state of Maryland. And if that happens, and when that happens, it is my hope that we will be working together to address those issues. Another example, you all know about Henrietta Lacks, but imagine that now there's a road named after her. You can take something that was tragic and make it positive, something that can help heal. And to my surprise, in the National Portrait Gallery hangs Henrietta Lacks. They call her the mother of bioethics. Isn't that interesting? From a tragic story to something very, very positive and uplifting. Let's imagine how we can do that together moving forward. So this is part of the cultural memory. When communities of color come before you and they may nod their head, yes, they understand, the cultural memory says underneath may well be these reservations that motivate their hesitancy around issues. And I think it's important that we as health professionals be sensitive to and aware of the cultural memory that comes with our patient populations and our ethical responsibility. In the aftermath of the Tuskegee study, the collective memory, as you can see, there were congressional hearings, and then the Belmont report was produced in '78 that lays out the ethical principles for biomedical research. These principles we still operate on today. Respect for persons, that's why you have to do informed consent. Beneficence, do no harm. The research must be balanced between risk and benefit. But we don't spend as much time on justice. The bioethics principle of justice says those who bear the burden of research should not be denied the benefit. And I would submit to you from that reparations article in the New England Journal, people of color in general and Black people in particular have been human subjects in research for decades and decades. And yet they are not benefiting from the output, the scientific output of that research. And that lack of benefit is reflected in the health disparities. So justice, those who bear the burden should not be denied the benefit. So I'm going to rush to the finish line, Dr. Pham, because I want to hear some comments and discussion. I'm going to take you to the Barbershop. This was a publication that went to every insurance company in the United States and every broker. And this notion of the doctor is in. I just want to make clear that Fred, who you see here, is not posing as a doctor, but he is the one that says it's okay to go see your doctor. He's the one that says it's okay for the doctors to come into my barbershop and meet my clients. And it's been an amazing success. It's called Health Advocates in Reach and Research. And in this scene here, you see a young pharmacist talking with this young man who probably hasn't seen a doctor or a pharmacist since he had his last physical in high school. And then you realize that these are powerful settings. These are trusted venues in the community. And we need these barbers and stylists to be part of the solution. Mr. Spry there is the president of the National Association of Black Barbers and Stylists for Health. And Mike Brown there is the vice president. And this is just an example of the types of research activities that we have been able to conduct in partnership with our Barbershop network. A physical activity intervention to reduce obesity in African-American women, a colorectal cancer screening initiative with funding and support from the Cigna Foundation, and oral bacteria microbiome research, where we actually collected biosamples in the barbershop. Now, Dr. Pham, I'm going to take you inside the shop, and I'm going to let your audience hear what the men had to say about the flu vaccine. And I'm hoping that they can help me meet their needs. So I'm going to I have to come out and then I have to go back in. I've learned this the hard way, to share one more time. And so hang in there with me as I get some of these windows to move away, and I can take you into the barbershop and hear directly from the men themselves. You can adjust your sound on your end. Here we go.
This is my good customer Jim. Been cutting Jim for over 10 years. This is my customer Kyrie. I've been cutting him since he was on phone books. This is a new customer Ty. This is my customer Jason. This is my first time cutting his hair. Jason, we just asking the people, how you feel about the flu shot?
They tell you it's like I'm assuming it's like a dead virus or something that they put into you. Honestly, I feel like it's another way for the government or the pharmaceutical companies to just get more money. In my opinion, I always just was anti any shot that I ain't need, even shots that we used to get for school and shit.
Personally, I've always taken the flu shot. Just the idea that you gotta prepare for it. Always thought that's always good.
How you feel about the flu shot?
I never take it.
Why not?
I just never do. And I never got the flu, so.
I just had my flu shot taken last Friday, so yes, I would take that.
Because they haven't gotten a flu shot before, so why should they get it now? Not only that, they're injecting you with the virus. No, thank you.
That they don't know how it's going to affect your body. Everything's not for everybody. You know what I'm saying? So just because it might have cured this person don't mean it won't mess this person's body up. Chemical reactions or anything.
But as far as the president, what he said, I don't trust it.
I definitely pay attention to what Fauci says. So if he says it's good, then I'm doing it. If it's a no from him, then it's a no from me.
Thanks a lot.
Okay.
All right.
Okay.
All right. I appreciate it, Joe. All right. There it is.
As he says, there it is. How we doing, Dr. Pham? Do I have another 2 minutes?
Yes, 2 minutes would be great.
Okay, I got to go back in. I'm learning how to work this thing here. And okay, so you heard directly from the men in the chair, and I think it's a challenge and an opportunity. Notice you had some that said no, they've never. You had people who said yes, but they're still all friends. They still all come together, and it's a place where we should be to demystify and address the underlying concerns. And we've done that in a number of ways, using graphic artists to take information and put it in a form that's a little more digestible and acceptable. I'll send the link to this to Dr. Pham. We did a proof of concept of a COVID-19 FDA-approved saliva test. Dr. Gales is still there. I could talk to him about this. Highly successful, 24-hour turnaround once the sample got to the lab. And here, the acceptability, the feasibility, it can be done, but we need to meet them where they are. We need to meet them where their level of understanding is, and we need an ongoing relationship. And it's in this context that our hair network is now moving to the next stage of literally building a health delivery systems through the Barbershop network. Since Maryland has global budgets, everyone's trying to reduce unnecessary readmissions. We have an infrastructure to help do better care coordination out in the community. And most importantly, I wanted to get to this before I stop, and it's our human-centered design and virtual reality simulations. And here's where I hope we can partner with MedChi in this whole notion of a new platform for retooling our health professions. And I just want to say, just thank you, Dr. Pham. This is a screenshot from Dr. Pham in the simulator with Archie and his mother. And maybe she'll share a little bit about the experience. But we believe, given the COVID and now the social distancing, the opportunity to bring technology as a solution to retool our health professionals, bring this simulation right to their desktops, I believe is a game changer. And it's with that I'll simply close and say this, that there is both danger and opportunity as we move forward. Danger and opportunity with the whole notion of these anti-racist institutions, the goal of the IDEA task force. Danger and opportunity. The danger is to assume that racism is not relevant in the scientific pursuit of solutions to eliminate health disparities. The danger is to assume that some populations will always suffer premature illness and death by virtue of their culture-bound lifestyle choices. And thus, the danger is to assume that the elimination of health disparities is impossible, that health equity is unachievable in a free market society. These are the challenges that we face. The opportunity is to recognize health disparities as an issue of justice because specific groups were subjected to systematic racial discrimination and denied the basic benefits of society, a violation of the social contract. That is our opportunity that COVID, of all things, has made possible. I want to thank my barbers and stylists and our funders. And now I'm going to turn the screen back over to Dr. Pham.
Great. Thank you. Thank you, Dr. Thomas, for that excellent presentation. I'm quite pleased you were able to join us tonight. And as you know, this is definitely a beginning and ongoing discussion. And with that, I know that everyone is sensitive to certainly everything that's going on around the world and what will be happening tonight at 9 o'clock. So I would love to call on our Reactor panelists then to go ahead with their comments. Dr. Tuesday Cook is a general and bariatric surgeon, and she's in private practice. And we also have Dr. Irfana Ali, and she's an emergency physician who operates 2 urgent care facilities in our area. And we also have Dr. Diggs, who's an internist and serves as the medical director of Riderwood Village Medical Center. So I ask each panelist to provide about a minute or 2 of their thoughts and react to Dr. Thomas's presentation. And I'd like to begin with Dr. Cook.
Thank you, Annette, for the great, and thank you, Dr. Thomas, for that excellent presentation. I was blown away by it, and I think it was so very informative and appropriate. And I wish that you could somehow get it on NBC and MSNBC and CBS and Fox News and all of the local outlets and national outlets, so that people can really get a taste of what is real. Science is real. Systemic racism is real. And I just think that your message needs to be really put out there for all to hear. And hopefully it will, as we get more people engaged and involved and strike while the iron is hot, which it is right now. I want to say, I think I was typing in the chat while I was listening to your presentation, and I really have encountered almost every single thing that you have mentioned there, from being a resident at Howard in DC in the 90s to fellowship in Hershey, where I was the only Black doctor and people would gravitate to me as such, to residency again at Howard in DC, to working in Maryland for a couple of decades. It just really has been these things. They're eye-opening to some, but are regular statements to others. You really touched on kind of the things that I wanted to ask about, but one of the things I wanted to say, and I think I just want to make it very plain for the docs that are here and for the docs who may watch this recording, because we know about the long and ethically bereft history of medical apartheid in this country, and experimentation on Black bodies from J. Marion Sims and the creation of the speculum and operating on Black women for 4 hours without anesthesia. And we know that papers, even as recent as 2018, state that physicians and health practitioners think that Black people don't feel pain the same. Those are in, national journals. What simple thing, if there is a simple statement, could we use to address patients who are not considering getting the COVID vaccine anytime soon, and for reasons that we very clearly understand, that mistrust is there. I gotta say, I'm a physician, but I'm Black first. And so, knowing the history, some people just know it on a surface level, but, some people know it even more. How can we address the fact that people are not going to want to be in these trials and not going to want to get the vaccine? How can we just almost as simply as we can start to address that involvement in trials, which I have not been telling people to get involved in, honestly, but how can we? That's my first question for you. And I guess my second one is just as a lay physician, I'm a surgeon, I do obesity surgery, and my Black patients may say, I don't want to lose weight. I don't want to lose my butt or my breast or my hips and thighs, because culturally that is something that we love. And so they don't want to get too small, but I try to talk to them about type 2 diabetes, how that is real and related to obesity, and hypertension, hypercholesterolemia, sleep apnea, all the things that we all as physicians on this panel know. But how can just the lay physician who doesn't have an MPH, which I'm starting to think that some of us will actually work towards now, how can the lay physician get involved in trying to educate themselves? I saw that you had modules there, educate themselves so that they can become more self-aware and recognize, their implicit bias and, how they can affect policy changes. So that, because policy is what governs everything. So how can the lay physician get involved in doing that? And then how can we address vaccinations? Yeah, I'm going to stop now.
Thank you, Dr. Tuesday. We've been in the task force meetings together, so this is the first time I've actually seen your eyes, and I'm so glad to meet you. I would say this, and I'll just be very simple on the first one. I think we have to listen more. If you notice what the barber did, he just asked the question. He didn't try to correct any misinformation. When I showed that same clip to my students, they said, Dr. T, I was trying to jump out of my chair to explain what the dead virus versus live virus. I was trying to explain. And then they realized that what Mike did was better. He simply validated their feelings. He didn't judge them. If you want a relationship, you got to stay around for the next part. So we've been in these shops now for 10 years. That's how we're able to do what we're doing. So the aim is not to, I'm going to convince you this or convince you that. The aim is, I want you to be an informed decision maker. I think if we go in with that attitude, we'll be fine. Because if people are making the decision that I'm not going to take a flu vaccine because they have something that's really a myth, then we want to correct the myth. And we don't want them to say, oh, I'll take the flu vaccine and anything else you got coming because I love Dr. Cook. I love Dr. Tuesday Cook. I'm gonna do anything she said. I don't even need to read the consent form. Just show me where to sign, Dr. Tuesday Cook. We don't want that either. We've got to educate our community to be informed decision makers. And you can no longer assume that someone with a high school education actually comes out knowing how the body works. That's not happening anymore. There's a lot of confusion out there. And the other thing, Dr. Tuesday, I think that Maryland should be the national model. We're the one place in the country that literally has that diversity across race and ethnicity, high income, middle income, low income. The state's not so huge that we can't address the entire state, but between Baltimore and Prince George's County, amazing difference we could make. And so I'm hoping that the like you say, the general practitioner, one of the things that we could do is to literally have a health equity certificate. You don't have to enroll it to be a degree granting student. MedCog, the University of Maryland, we right now, through your IDEA task force, can say, you know what, we're going to sponsor or we're going to support a certificate that you can get right there online, at home. And I do think that the simulator is the game changer for actually changing behavior. So we'll come back to that.
Thank you.
Thank you. Dr. Ali? Thank you, Dr. Cook.
Thank you, Dr. Cook. And Dr. Thomas, thank you so much for this absolutely wonderful talk. I was so impressed by your first motto that you said with building bridges, building trust, and building communities. And the fact that you actually took it into reality where you created this barbershop network. I was so impressed by the creativity and the thinking that was involved in doing this, and the fact that you are able to take questions and give answers in a community where there is so much distrust. And the fact that you were able to recruit the whole barbershop community, I think it's just amazing. So I just wanted to commend you on this barbershop network that you created. And I would be very happy to be a part of this. And I'm happy that we're recording this, because I think there are a lot of physicians that will be able to watch this again and unpack a lot of the things that you've told us about opportunities that we have, that we can be a part of the change, because we all know that there is a problem. We just, many of us don't have the tools to know how to make the change. I mean, obviously, I'm also from a minority community. I did residency during a time when, and in New England, where there are not too many, brown people in emergency medicine, especially. So, I mean, I also was, asked questions that perhaps non-brown physicians may never have been asked, or non-women physicians may have been asked. So I can see where Tuesday is coming from also. But I just wanted to comment that we are very happy to have had you speak with us, and it's just a huge wealth of information that you've given us and many different resources that we can use. Thank you very much.
Oh, thank you so much, Dr. Tuesday. When we had brought the physicians into the barbershops, they light up. They're so happy. They're excited to be in a place that is safe for the men. They meet them as neighbors, not as patients. And when they leave, they say, can we come back? These are the docs. Can we come back? And that's the structure that we need to put in place so that it's routine and not by accident, not a pre-conference workshop. But whenever we've taken them in, they have kind of, this is what I'm missing. This is what I was missing in my medical education. This is what I'm missing now in my practice. Here I am in this Black barbershop meeting these men. This is why I became a physician. They get reconnected with their prime motivation. Dr. Pham, we can do that.
Thank you, Dr. Ali. And last but not least, I'd like to call on Dr. Diggs and your thoughts.
Can everyone hear me?
Yes.
Yes. Thank you, Dr. Thomas, for a wonderful presentation, and it's great to see everybody. I certainly look forward to the day when we can be together in person. Dr. Thomas, just so you know, I'm a dyed-in-the-wool Baltimorean, and my mother grew up in East Baltimore, and in our family, we talked about this probably every single Thanksgiving and Christmas dinner, how when you were younger, if you were out on the street at night, your parents warned you that you could be snatched, that people from Hopkins would come out from the hospital and take you in through a back door in a basement, and you may or may not ever be seen again. And that myth or lore survives to this day in my family. My father probably never saw a white physician until he was 70 years old. He just didn't trust a white physician. My grandfather died at Providence Hospital, which was the Black hospital in Baltimore. He was stabbed by one of his employees with simple abdominal stab wound. He should have been cared for, but unfortunately, due to lack of supplies and problems at Providence, he died from sepsis. And so these kinds of things are very real to me. So these are not things that I read about in a journal. These are things that I experienced. And in my medical career, right from the beginning, I saw disregard for people of color right from the beginning, attendings using first names to people who were 20, 30 years older than them, or elderly Black patients who should have been addressed by their surnames were addressed by their first names. As if, we don't really think that calling you by your last name, you don't warrant that. You don't deserve that. I saw that a lot. I saw therapies that were withheld from Black patients. I saw insurance fraud. I saw language and cultural bias. And now, even moving into the 21st century, I read an article recently about Prince George's County having a problem with predatory testing schemes, where people will come in with a vascular machine to a church fair at one of the mega churches in Prince George's County, get everyone to sign up. And then when you get your ultrasound, they tell you, oh, you better come into my office because I need to do more tests on you. And then those tests are like $500, $600. And a lot of these patients really cannot afford those tests, but they're afraid that if they don't do it, something might be wrong with them. So it's kind of a medical version of the predatory lending that we saw early in the 21st century. So I wanted to speak, though, on a positive note to how the medical societies and organized medicine can respond to this challenge. And I was interested to see that the AMA has got a strategy for collaborative, I guess, to collaborate, to encourage collaboration on this effort. And their framework says they want to advocate for healthcare access for all. They want to promote care equity or equity of care for the patients. And one of the things the AMA is interested in is increasing workforce diversity. So not just at the community level, but also in the public health arena, because we find that in the public health arena, as 20 or 22, 25% of public health officials are actually leaving the field, and the pipeline for replenishment is really slim, and the minority participation in that pipeline is even slimmer. The AMA is also interested in influencing determinants of health and trying to model commitment to health equity amongst its members. And so I think that's a call to all of us to step up our game and become more aware of this problem, which, as you see, has morphed and changed over the years, but that legacy is still very much present, and certainly in the Black community. So I will stop, and I think we're supposed to open up for questions. Dr. Pham is in charge of that.
Before we do that, let me just say thank you so much, Dr. Diggs. And I don't know how many times you've told that story about your own personal experience and who you've told it to, but I'm sure glad you told it tonight.
Thank you.
Because I've met many physicians of color. They don't necessarily, the environment doesn't lend itself to that kind of disclosure, but we're there now. COVID has forced us to look at this. And I think if we look at it, don't run from it, we can get through this, but we've got to go through this part first. Because if the community doesn't know that you know the burdens that they have and the suffering they've been through, how can they trust you?
Right.
And there's a time when you're going to have to share something about yourself. Now, I saw Dr. Carson, her eyes really lit up when she heard you tell that story, Dr. Diggs. So I know there's somebody out there, maybe many people, who did not know that. And the last thing I'll say, at the University of Medical College of South Carolina, in our lifetime, construction site, human remains in a sub-basement. They brought in the Smithsonian to basically set up an anthropological dig. There's a book from the National Academies called Bones in the Basement. Bones in the Basement. And it is the history of modern medical education. The church prevented medicine from defiling the body. You could not do autopsies. The medical schools that jumped out ahead were medical schools that broke that moral commitment and they advertised that you'll come to our med school, you can actually work on human bodies. They recruited a Black man who had respect in the community, Dr. Diggs, and he was hired to identify the graves of Black people they dug up and used for autopsy. That is in our lifetime. It's in a book. My point is that we can develop the curriculum that will prepare the MedChi physicians and Maryland physicians for this future. The future is more patient populations that come from racial ethnic minority populations. The future is a much more diverse community. And the future is we have to address these chronic diseases because COVID-19 is not the only infectious disease that we're going to see. Okay, so now let's get to work and get this done. You're going to have legislators that will applaud you if you embrace this commitment.
That's right. Thank you, Dr. Thomas, for circling back around and bringing that all together. I think, really, this is just the beginning, as you said, in talking about building bridges across communities and everything. I think this can only be possible, certainly, if we're with your candor, Dr. Diggs, speaking out, sharing stories. Really, that's the heart of it, is getting down to the emotions of it as well, so that we can begin to understand and empathize with each other. In the interest of time, and I don't want to, say that it's not important, because this is a great topic, and I'd like to actually offer out that hopefully we can even have a follow-up program just specifically dedicated. So like Dr. Thomas, you said, it's just the beginning. And I wanted to add in, you've been mentioning the MedChi task force, of which, I've been a part of. I want to throw out there, this has been under the leadership of Dr. Michelle Manahan, the current president of Maryland State Medical Society MedChi, and as the Inclusion, Diversity, Empowerment, and Advocacy Task Force. If you're interested, please reach out to, I see many members of the task force, of which Dr. Thomas is a part of, Dr. Cook, Dr. O'Connor, I see Russell there, I've seen you on the meetings as well. We're going to take 2 questions, maybe as I'm sort of wrapping up here, if you want to add something to the chat, if someone has a pressing question, if you can start putting that in the chat, and then maybe Dr. Thomas, you'll be able to see that. But while I do have the mic, I do want to say again, thank you, Dr. Thomas, Dr. Cook, Dr. Ali, Dr. Diggs. Your comments have been, quite informed, encourage me as a physician to inwardly reflect on my own effectiveness in caring for vulnerable populations. Again, like you said, this is only the beginning, and really with our active engagement, hopefully we'll be able to continue to move forward and really march on. And let me see if anybody has had any questions in the chat. It looks like everybody is well informed and wants to move on with our program, and I think that just says that you've left us a little speechless, and we need to follow up with a program in the future. So thank you, Dr. Thomas, but I appreciate you being here tonight, and it was an honor.
If you were able to curate the text, I'm happy to go back through with our grad students, and we can you actually might have the outline of an essay for the theme issue right there in the chat box. Let's talk about that, Dr. Pham. Thank you very much for your time and attention this evening. I hope to see you all again very, very soon.
Great. Thank you, Dr. Thomas. You have a good night.